Good day, everyone. Today we are going to be discussing a very important topic in the field of obstetrics called antepartum hemorrhage. And this will be the first part of a two-part or three-part series. In this part, I'll be talking about placenta previa after introducing the whole concept of antepartum hemorrhage. So let's begin. So this will be the outline I'll be following as we go on. We'll first introduce antepartum hemorrhage, then we'll talk about placenta previa in this video. In the part 2 of the video, we'll talk about abruptio placentae. Then we will now talk about indeterminate bleeding in pregnancy. So, an antepartum hemorrhage is bleeding from the genital tract after 28 weeks of gestation, but it's usually before the birth of the baby. As you all know, postpartum hemorrhage is bleeding after the birth of the baby, postpartum. There are three main causes: placenta previa, abruptio placentae, and unclassified or undeterminate causes. We all know that placenta previa is the presence of the placenta at the lower uterine segment. Abruptio placentae refers to the premature separation of the placenta, and unclassified causes or indeterminate causes are numerous, from vasa previa to velamentous insertion of the cord, and when the time comes we will talk about that. But for today's video, we are going to be talking about placenta previa. This is another division of the causes of antepartum hemorrhage. They can be placenta causes, extraplacental causes. Then they could also be unexplained causes. They may be placental or otherwise. The placental causes, as we can see, are either previa or abruptio. Extraplacental causes are local causes within the cervix or genital tract, such as the cervical polyp, carcinoma of the cervix, or varicose veins. And the unexplained causes are mostly placental, and as I mentioned before, they are numerous, which we'll get to when the time comes. So this is a placenta previa. As you can see, this is the normal placenta. This is the previa located placenta. This is an abruptio placenta. You can see the placenta is separating prematurely. And these are some causes of indeterminate causes of APH. Like you can see a vasa previa, meaning the fetal blood vessels are in front of the presenting part, which are prone to rupture whenever delivery is about to occur, or more specifically when the amniotic fluid, the amniotic membrane is being ruptured in labor. So let's go to placenta previa. So placenta previa, as I've said earlier, is an implantation of the placenta at the lower uterine segment. So it could partially or completely cover the internal os, the internal cervical os. To be more specific, it can either lie close to the internal os, partially cover it, or completely cover it. Previa comes in from a Latin word which means in front of. So generally, it affects 1/3 of antepartum hemorrhage cases, and it occurs about 0.5 to 1% of hospital deliveries. Some of these incidence rates may vary from country to country, hospital to hospital, center to center. Some of the risk factors are numerous. It could be multiparity, that's more than one child, advanced maternal age greater than 35 years, previous uterine surgeries, whether it's cesarean sections, hysterectomies, myomectomies, and others, large placentas, or generally placental abnormalities. So if the placenta is large, if you have abnormal placenta such as the succenturate lobe placenta, lifestyle habits such as smoking. It has been known that smoking increases the placenta size because of compensatory hypertrophy of the placenta due to the increased amount of carbon monoxide in the blood. If there's a history of uterine instrumentation, such as dilatation and curettage, it can increase the risk of placenta previa. And also multiple pregnancy, because multi-pregnancy can either have a very large placenta or more than one placenta that has an increased risk to be located in the lower uterine segment. Generally, the two main things that can increase the likelihood of placenta previa is how large the placenta is, how abnormal the placenta is, and how much scarring the uterus has undergone. It could be scarring from surgeries or vaginal procedures or from previous pregnancies. That's why it's common in multiparous women. So let's talk a bit of pathophysiology. What are the ways placenta previa tends to occur? So there's a dropping down theory where the fertilized ovum descends down to the lower uterine segment. Normally, the ovum is supposed to implant in the middle or upper uterine segment. As we said before, uterine scarring may play a role in pushing it downwards. We also have the problem of capsular placenta formation. Here, the placenta formation from the first few weeks of life is abnormal. There's a part of the placenta called the chorion frondosum, and there's a part of the decidua called the decidua capsularis and the decidua parietalis. From what you know about embryology, the decidua parietalis and the decidua capsularis fuse to form the amnion. As you can see here, these two fuses to form the amnion. And the chorion frondosum becomes the definitive placenta. So it's believed that in placenta previa, this fusion does not occur properly, and part of it still forms the placenta, increasing its size and increasing the likelihood for it to be pushed down to the lower uterine segment. There's also the defective decidua theory. So the decidua reaction are cellular changes within the endometrium that occur after implantation has happened within the endometrial lining. It's thought that this reaction is not proper and is more widespread than it should be. The decidua reaction should actually be more localized at the site of implantation, but if the reaction is more widespread, most of the chorionic villi can spread beyond the margins or the region of implantation and increase the likelihood of it entering the lower uterine segment. And as you know, if there's a large placenta as seen in multiple gestation, as we mentioned, is smoking, it can extend to the lower uterine segment. So there are some pathological changes that occur in patients with placenta previa, mostly around the placenta. Placenta may be large and thin. It may have tongue-shaped extensions. There may be evidence of degeneration, infarction, calcification. They tend to have morbidly adherent placenta that is unusually attached to the surface of the inner surface of the uterus, which is the endometrium. The umbilical cord can have some abnormal formation, such as the battledore or the filamentous insertion. Okay, and the lower uterine segment is usually hypervascular, is usually soft and friable. Later on in the presentation, I will let you know that you may even do Doppler studies on the placenta to indicate or appreciate this hypervascular nature of the lower uterine segment in placenta previa. So these are some examples of the abnormal placentas that are common in placenta previa. So we have the filamentous insertion. You can see the cord is not inserted into the placenta directly. It is inserted somewhat onto the membrane before entering the placenta, the chorionic axis, the amniotic side. Then this is the succenturate lobe, an extra lobe connected by placenta vessels is also present. the circumvallate placenta, the amniotic side is smaller than the chorionic side. Circummarginate placenta. The amniotic side is of adequate size, but the chorionic side is still larger, creating a marginal region of the chorionic part of the placenta. Then we have the marginal insertion of the battledore. Here the umbilicus is inserted at the margin towards the end rather than at the center. And we also have the bilobed placenta. Here it is inserted on the amniotic side of the placenta, but is in the middle of two lobes of the placenta. So classification. Generally, the placenta previa can be classified into two types, but they are usually similar. Type 1, type 2, type 3, type 4, or low-lying, marginal, partial, or complete. So for the type 1 or low-lying, the placenta is located at the lower uterine segment, but it hasn't even covered the internal os. In type 2, the placenta has encroached towards the internal os, but has not covered it. In type 3, it's not a correct representation though, but in type 3, the placenta has covered part of the internal os, but has not completely covered it. And in type 4, the placenta has completely covered the internal os, and it's what we call a complete placenta previa. These classifications can be specified into anterior and posterior. So if you have a type 2 placenta previa and the placenta is posterior, it will be referred to as type 2 placenta B or type 2B. Type 2 meaning it has encroached the internal os but has not covered it, and B means is posterior. If it was anterior, it will be denoted type 2A, meaning is a type 2 placenta and placenta is anterior. So as we said, this is the other classification. So we can also grade the degree of severity of placenta previa, usually based on the classification. So there's the mild degree, major degree, and we even have the dangerous type. So the mild degree is any type 1 and type 2 that is anterior. It's generally believed that anterior placenta previas are less dangerous than posterior. We also have the major degree, which is type 2 posterior, type 3, and type 4. So from type 3 and type 4, we consider that as major placenta previa. Then from type 2 posterior, that is what we also consider as major placenta previa. Generally, the dangerous type is referred to as the type 2 posterior for certain reasons. We know that type 3 and type 4 have already encroached and covered the internal os. But most of those cases, the management decisions are usually very easy. We know that they mostly are recommended for cesarean section. But for type 2 posterior, where it hasn't encroached the internal os, but their placenta location is posterior, and that presents with some problems, as I'm explaining now. Because they are posterior, the placenta bulk can compress the pelvic inlet, so it will prevent the fetus from engaging. Later on, we'll talk about how there's high presenting parts in examination of placenta previa patients. Also, there's an increased risk of bleeding because the placenta cannot be compressed by the presenting part. And there's also an increased chance of cord compression or cord prolapse, which can lead to fetal hypoxia. So you must note that when you have a type 2 placenta that is posterior or a type 2B, it is particularly dangerous because you may not have cesarean section indicated, and if they go into labor or late in pregnancy, they could have more torrential bleeding. Their more likely to have cord prolapse or cord compression, which will lead to far worse outcomes later on or after delivery. So how does bleeding occur in placenta previa? So we know we are talking about antepartum hemorrhage. So how does bleeding occur when a patient has the placenta located at the lower uterine segment, almost close to the internal os? So we know that late in pregnancy, the placental growth is slower, but the lower uterine segment continues to expand and dilate. We know the term well-developed lower segment. Lower segment is actually meant to thin out, widen as pregnancy approaches term. So because of this differential in growth, the lower uterine segment can stretch and lead to some shearing and separation of the placenta from the uterine wall. Then also trauma can also trigger bleeding in placenta previa. The type of trauma we usually see is trauma from vaginal examination. That's why it is paramount that anybody who comes with antepartum hemorrhage, you should not do a vaginal exam until you have ruled out placenta previa. Maybe during sex, coitus, the sexual act can trigger bleeding, and it can also occur in external cephalic version, of which that is not done that frequently. The origin of blood is primarily maternal. It's a common question in many examinations. In placenta previa, the bleeding is usually of maternal origin. Then in vasa previa, the bleeding is usually of fetal origin. So let's talk about some of the clinical symptoms. So the primary symptom is vaginal bleeding. Okay? The vaginal bleeding is usually sudden. You see a woman who has seemingly been fine, suddenly just has bleeding through her vagina. Characteristically, it is painless. It may just be recurrent. So a woman may come in antenatal and tell you, doctor, I'll see blood today. 3 days time, I'll see another one to stop. 4 days time, I'll see another bleeding to stop. But there's a tendency for those bleeding episodes to become worse as time goes on. There's usually a warning hemorrhage, meaning there's an initial bleeding that is somewhat mild, but it should serve as a warning for a more torrential bleeding that may occur later on. There is also labor-associated bleeding. Many of the antepartum hemorrhage cases can occur in labor. So you may see bleeding in labor. You may not take it seriously, but you now discover that it may be due to placenta previa. Then as a characteristic, pain is absent. Pain is only present if there's already labor, but characteristically, there's no pain in placenta previa. So let's talk about the signs. So the general condition of the patient would be dependent on whether there's the level of blood loss that has occurred. So somebody with mild bleeding will still look generally stable. There will be no pallor, there will be no lethargy. The pulse rate, blood pressure will be normal. But once bleeding has become torrential, there will be evidence of circulatory collapse. So you may see lethargy, you may see pallor, you may see cold, clammy extremities. Cardiovascular exam, you may see tachycardia, hypotension. So it's very, very important to determine how much blood loss has occurred, and it may reflect the clinical state of the patient. So when you examine the abdomen, the uterus is usually soft, relaxed, and non-tender. When we talk about abruptio placenta, you will see that it is the uterus or the uterine examination is almost opposite of what you get in placenta previa. If you examine well, you may see some degree of malpresentation. You may have breech presentation, transverse line, and unstable line. The head may be floating. The floating head is simply a head that is not engaged into the pelvic brim. This is because the placenta is at the lower uterine segment, so it's occupying space, preventing the head from engaging, which should actually occur from 36 to 37 weeks of gestation. We have the Stallworthy sign, which is transient fetal bradycardia. when you compress the head onto the pelvis. It is not usually done because nobody expects the doctor to stimulate fetal distress by any examination, so it's not usually commonly done. As I've said before, you do not do a vaginal examination. The best you can do is to do a vulval inspection and see how much bleeding is present. Don't do a digital examination. I won't even advise doing a vaginal instrumentation, but if you are careful, you can just insert your speculum just slightly into the vaginal introitus and examine the nature of bleeding. As I've said before, do not do a vaginal examination. If a vaginal examination must be done, do it in a controlled setting, like in the theater, with all your resuscitation equipment, blood transfusion ready, IV fluids. In fact, you should be ready to do a cesarean section if you are going to do a vaginal exam. Generally, in a practical sense, an obstetric ultrasound is enough to diagnose whether you are dealing with placenta previa without the need to do a vaginal examination. So, how do you diagnose? So, once you have painless vaginal bleeding from 28 weeks gestation, you should assume it is placenta previa. Okay? You can do some imaging techniques such as a trans-abdominal sonography. It's relatively accurate after 30 weeks. There are some limitations to this. So, for example, if the patient has a full bladder, it may cause false positive results. If the mother or the patient is obese, it may not allow you to visualize the placenta properly. Then if it's a posterior placenta, there may be difficulty localizing it because of issues like acoustic shadows from the presenting part. It may block the view of the posterior placenta. Then there may also be a lack of landmarks posteriorly for you to be able to know where that placenta is. Generally, from experience, location of the placenta is not usually an issue because the majority of the placenta is already at the mid-uterine segment. So if you can trace it down using your ultrasound probe, you may get some degree of clarity as to where the placenta is located. Other ones that you can do are the transvaginal ultrasound, transperineal ultrasound, color Doppler along with your ultrasound. Those can help detect venous blood flow within the areas of the placenta, which supports your diagnosis. And if you're in a center that has the facilities for such, you can do an MRI, but this is usually considered unusually costly and time consuming. This is a trans-abdominal ultrasound. You can see the bladder, you can see the placenta. As I said, if you can trace the placenta from the mid-uterine part, you can see its extension down to the lower uterine segment and even in front of the internal os. I would like to ask, what do you think what is the class of placenta previa this is? Write your answer in the comments. So, common differential diagnosis. We said abruptio placentae, cervical lesions. In fact, anything that can cause antepartum hemorrhage, bleeding after the 28 weeks of gestation, can be confused with placenta previa. But as I've stated before, it's very, very important to have a high index of suspicion. Whenever a woman who comes from 28 weeks with bleeding and the bleeding is painless, think placenta previa first. So the management, how do we treat these patients? I'll divide the management into two. What is your initial management when the patient comes in? What are the things you do? And what is your delivery plan? Because in obstetrics, your mode of delivery is an important aspect of your management. After all, the goal is to deliver the baby safely so that mother and child are happy. So, for all APH cases, you have to admit them. No matter how mild, it is generally preferable, except the patient signs a consent refusing admission. It's because many APH cases can become severe in a very, very short while. We mentioned the concept of warning bleeding. You should put an IV line, a large bore IV line, so that you can give large amounts of fluid. Fluid resuscitation, very important. Administer crystalloids, normal saline, Ringer's lactate. If the patient is in shock, treat the shock appropriately. The patient will need blood transfusion. Mostly blood transfusion will be needed after estimating the relative amount of blood loss. Then important investigations are your hemoglobin level, blood grouping and cross-matching to be able to get blood for transfusion, then your ultrasound to confirm diagnosis. Most of the aspects of this initial management are obviously dependent. You prioritize based on the severity. So patients who are in severe bleeding probably need to resuscitate the patient with IV fluids and blood transfusion before you even start thinking of ultrasound diagnosis. Patients who are more stable with less severe bleeding or mild bleeding, you can afford to focus on diagnosing or confirming your placenta previa or any other diagnosis before other aspects of resuscitation and investigations are done. So in delivery, there are usually two to the delivery plan when you are planning on how to deliver placenta previa. You have the expectant management, which is usually from the McAfee-Johnson protocol, and the active or definitive management. Generally in obstetrics, we know expectant management is the watching and waiting, and active management is the interventional management that you give the patient. So the expected management, there are some indications. The gestational age should be less than 37 weeks. So if the patient is in term, you have generally in most things in obstetrics, once the patient is in term from 37 weeks and above, you need to institute active management. The patient is hemodynamically stable. So the patient is not in shock, it's not in pre-shock, it's not at risk of shock. There is no bleeding, no active bleeding. Although in cases of mild bleeding, you can still do expectant management. And the fetal heart rate is reassuring. So you've done your fetal heart rate, you've done your stress tests, you've done your biophysical profile, and the fetus is in good condition. So you can do expected management when you watch and wait. Okay? If you are going to do expected management, you must be able to provide the cesarean section and blood transfusion on demand. In fact, anybody with placenta previa who has been admitted in your center should be able to have blood transfusion on demand without any logistic delay. And if need be, they should be able to perform the cesarean section as quickly as possible if there is need. Then while you are observing, as usual, you need to be monitoring the mother and the baby to detect any changes in their clinical condition. If there's any change, you intervene as quickly as possible. Some of the components of this expectant management is bed rest, routine investigations, as we said before, PCV, grouping and cross-matching, urine protein, which are standard tests for pregnant women. You give hematinics, give blood transfusion as needed. Some of these patients are anemic. Some of these patients have had some moderate to severe bleeds that have actually stopped, and they may need blood transfusion to replace the lost blood. Then there could also be, you need tocolytics, drugs that can reduce uterine contractility. Good example is magnesium sulfate. Here in our center we can use nifedipine, we can use salbutamol, but there are so many others. Then if there's RH, if the mother is RH negative, you give RH immunoglobulin, because in these cases mixing of the maternal and fetal blood has already occurred. Then if the patient is less than 34 weeks, you give steroids to promote lung maturity. That's usually common for most expectant management in obstetrics. In some select cases, you can provide home care because I'm a family physician and we believe in patient-centered care. So we do not impose management on patients. So in cases where the patient is very close to the hospital, there's ease of transport, and you can assure that the patient will rest, and the patient understands completely the risks of staying at home, then you can provide home care, providing the other treatments that you normally give in the hospital. And whenever there's any bleeding or sign of bleeding, the patient should rush straight back to hospital. So when you terminate expectant management, if there's significant or recurrent hemorrhage, some patients will just have heavy bleeding and you just have to intervene. Some patients may have recurrent hemorrhage, so they're in hospital and they bleed. Today they bleed, it stops. Tomorrow another bleeding occurs. So many times the recurrent hemorrhage is already an indication that you should intervene and deliver this baby. If there's fetal death or there's major malformations, that is a bit unfortunate. But once the baby is dead, there's no point continuing with any treatment. And once you detect any major malformations while monitoring the baby on ultrasound, you should also go to active management. Then after the baby has completed 37 weeks, so after the 7 weeks, you should make effort to deliver the baby. There's no point keeping a placenta previa beyond 37 weeks. So active management. So here you just deliver the baby. Okay, as I said, there are many indications similar to what we said in the expectant. When you are beyond 37 weeks, when labor has occurred. So if labor has occurred, there's nothing you can do. You just have to deliver. If the patient is hemodynamically unstable, if there's fetal demise, the baby is already having issues, bradycardia, tachycardia, poor stress testing. And I'll also add if there's severe hemorrhage. So even if the patient is stable, but on examination, hemorrhage is severe, if they stabilize and that severe hemorrhage persists, you have to perform active management. So when you want to deliver, what are your modes of delivery? Majority of cases of placenta previa are delivered via cesarean section, and it's usually indicated if the placenta edge, if it can calculate it, if it's less than 2 cm from the internal os. From the knowledge I knew while in medical school, generally from placenta previa type 2B and beyond are delivered via cesarean section, while placenta previa type 1 and 2A, type 1A and B, that anterior and posterior, and type 2 anterior can be delivered via SVD, spontaneous vaginal delivery. So the type of cesarean section is usually lower segment, but some cases may require classical vertical incision on the uterus. In vaginal delivery, as I've mentioned, some cases of major placenta previa, hemodynamically unstable patients with malpresentation, and if you've documented contracted pelvis, should not be delivered vaginally. So if there's any other indication for cesarean section outside the type of placenta previa, you should deliver via cesarean section. And also if there's severe bleeding, hemodynamic instability, you should not deliver vaginally. So what are some of the considerations you should have when doing a cesarean section for placenta previa? Cesarean section for placenta previa can be quite challenging, and it's even usually advised that it should be done by the most senior obstetric personnel available. So you can do the lower segment cesarean section. It provides better exposure. You can manage any bleeding that occurs. You can conserve the uterus if there's accreta. I told you that placenta previa is notorious for having placental abnormalities. The disadvantage is that you may cut through the placenta, especially if you have placenta previa, maybe type 3 or 4 anterior. You will cut through the placenta. And those kind of placenta previas, those kind of cuts can cause severe maternal and fetal hemorrhage. which will require you to be very quick in your incision and very quick in your resuscitation. Then because of the location of the placenta at your operation field, at your incision site, it may be very, very difficult to control bleeding at the lower uterine segment. So other strategies you can use is to use a vertical incision. That's a classical cesarean section. You may ligate any bleeding vessels that you have before you make the incision, maybe on the anterior abdominal wall. Then you should promptly clamp the cord and milk it to prevent hypovolemia in the fetus. So I said, once you cut through that placenta, you need to quickly deliver the baby, clamp the cord to prevent severe blood loss. Then you suture bleeding points. You can use tamponade, you can use aggressive uterotonics and oxytocin, ergometrin, and you can use isthmic cervical sutures. That's similar to what you do when you do a cervical circlet for any intractable lower segment bleeding. So if you decide to do a classical cesarean section, you should know that there are some advantages. Here there may be rapid access. You may not disturb the placenta. There's less likelihood of fetal blood loss because you're less likely to cut through the placenta. There may be increased maternal hemorrhage because classical cesarean sections bleed more than lower segment cesarean section, and there may be issue of high post-op complications. So generally, we recommend that a senior obstetric personnel should be the one who does the surgery. Anybody in shock should have immediate surgery. So generally, also, it has been found that a longitudinal abdominal insertion is much more preferred. Then also you check the natal hemoglobin. In fact, you should even have a pediatrician stand by to help in your resuscitation because there's a high likelihood that the fetus may have developed anemia. So what are the complications? The maternal complications can have coexistent abruption. There could be malpresentations, which we mentioned before. Preterm labor, the uterus can become unnecessarily or unusually contractile. The membranes may rupture early. There's an issue with cord prolapse. Cervical dilatation may usually be slow. There could be postpartum hemorrhage. They could have a morbidly adherent placenta. Placenta could be retained. There could be increased risk of sepsis in the postpartum period. There could be uterine subinvolution. So there are a lot of complications that occur when a woman has placenta previa. And the reasons why are somewhat self-explanatory. The fetus, there could be low birth weight because many times you may need to deliver these babies prematurely. The babies tend to have asphyxia because the placenta may be compressed during delivery or cut through during cesarean section. Could be IUFD because the placenta is already abnormally located. There's reduced perfusion. The delivery process may compress the placenta and cause fetal hypoxia. There's an increased risk of cord accidents, cord prolapse, filamentous insertion of the cord. There's also an increased risk of congenital malformations because, as I mentioned before, placenta previa is always associated with placental abnormalities. So in the same vein, the abnormalities in the placenta would also be seen in the formation of the baby. So what are the ways we can prevent this? So very good antenatal care. Standard antenatal care will detect placenta previa as quickly as possible. And you can now make your management decisions from them. Ultrasound surveillance. If you are doing your, in fact, if you do your ultrasound, your standard ultrasound regimen during the antenatal period, you are going to detect this. At least you will detect the low-lying placenta and you can monitor it as time goes on and see whether it actually becomes a placenta previa after 28 weeks. You should counsel the patient on any hemorrhage in pregnancy. So once a woman bleeds, generally most women, once they see bleeding, they tend to come to hospital as quickly as possible. But any lady who has, you should also emphasize that any bleeding in late pregnancy is very, very important, and they should come to hospital as quickly as possible. And in centers where the facilities are available, you can do color Doppler screening for placenta accreta, which is a morbidly adherent placenta. Thank you very, very much. So after this, we'll go to the part 2, which will be talking about abruptio placentae and the other indeterminate causes of placenta previa, of antepartum hemorrhage.